Hello friends, welcome so much to my YouTube channel, the Dr. KRISHNAN Lecture. I am Dr. Ramesh Krishnan, doing super specialization in neurology at Indraprastha Apollo Hospital, New Delhi. Do subscribe to my channel for regular updates on interesting topics of the medical science. In this lecture video, I will discuss about diagnosis of multiple sclerosis. Now, the optic neuritis finding in the patient with MS include unilateral short right optic neuritis, which is demonstrated in this figure, and MRI further explains the optic neuritis findings in the patients with MS. Here, the left-sided optic neuritis, which is shown in the MRI. Then myelitis in the patients with MS are multiple focal short spinal cord T2 lesions located in the peripheral white matters. The figures demonstrate the multiple small short segments T2 lesions in the sagittal views, and the axial views shows the peripheral white matters lesions. MRI further explains the myelitis finding in the patients with multiple sclerosis. Brain lesions in the patient with MS include a small peripheral T2 lesions in the anterior medulla, as well as multiple T2 lesions in the peripheral pons, trigeminal nerves, and aviating to the fourth ventricles. This MRI shows a small T2 lesions in the anterior medulla, as well as the lesions in the peripheral pons, trigeminal nerves, as well as adjacent to the fourth ventricles. This figure further explains the brain lesions in the patients with MS. This is the lesions in the anterior medulla, and these are the lesions in the peripheral pons, trigeminal nerves, and adjacent to the fourth ventricle. Then these lesions could be multiple oval periventricular juxtacortical deep white matter lesions, can also be seen in the patient with MS, as well as periventricular white matter hyperintensities called as Dawson's finger, or white matter T2 lesions and one cortical lesions. Lesions showing C-shaped open or closed ring enhancements. The figures, these are the figures which shows periventricular, cortical, and deep white matters lesions. These figures further explains the findings in the patient with MS, and this is the Dawson's finger, which is the periventricular white matters hyperintensity. These all findings could be seen in the patient with multiple sclerosis. Now, the features of 2017 McDonald criteria that differs from 2010 criteria include cortical lesions together with juxtacortical lesions can be used to fulfill MRI criteria for decimation in a space. Both symptomatic and asymptomatic lesions can be used to fulfill decimation in a space or time criteria. Presence of CSF-specific oligoclonal bands can demonstrate the decimation in time in those presenting with typical clinical syndromes and meeting decimation in a space criteria. Now, typical and atypical presentations of clinically isolated syndrome or relapsing remitting multiple sclerosis. Typical presentation include acute unilateral optic neuritis, double vision due to internuclear ophthalmoplegia or sixth nerve palsy, facial sensory loss or trigeminal neuralgia, cerebellar ataxia or nystagmus, partial myopathy, sensory symptoms in CNS pattern, Lermite symptoms, asymmetric limb weakness, urge incontinence or erectile dysfunctions. These are the typical presentations in multiple sclerosis. Atypical or red flag presentation that can suggest alternate diagnosis include bilateral optic neuritis or unilateral optic neuritis with poor visual recovery, complete gaze palsy or fluctuating ophthalmoparesis, intractable nausea, vomiting or hiccups, complete transverse myelopathy with bilateral motor and sensory involvement, encephalopathy, subacute cognitive decline, headache or meningismus, isolated fatigue or asthenia, as well as constitutional symptoms. So these are the atypical presentations in the case of multiple sclerosis. Now the MRI red flags mnemonics include: M stand for meningeal enhancement, I for indistinct lesions or increasing lesions, M for macro or micro bleeds, I for infarct, C for cavities as well as complete ring enhancement, S for symmetric lesions sparing U fibers, sclerosis, a spinal cord longitudinally extensive lesions greater than 3 spinal cord segments. Then laboratory investigation to consider in atypical clinical presentations include: if the patient is having bilateral optic neuritis or unilateral optic neuritis with poor visual recovery, then aquaporin 4 antibody, MOG antibody, toxic or metabolic panels including vitamin B12, copper, infectious screening including Bartonella, syphilis, Lyme's, autoimmune screening like ESR, C-reactive, ACE level, genetic testings for liver, hereditary optic neuropathy as well as optical coherence tomography should be considered. If the patient is having complete gaze palsy or fluctuating ophthalmoparesis, then X-ray, chest X-ray, PETs, tissue biopsy for sarcoidosis, malignancy screening should be considered. If the patient is having intractable nausea, vomiting or hiccup, then aquaporin 4 antibody and anti-MOG antibody should be considered. Complete transverse myelopathy with bilateral motor and sensory involvement, then aquaporin 4, MOG, autoimmune screening, infectious screening should be considered. Encephalopathy, subacute cognitive decline, headache, meningismus, fatigues, asthenia or constitutional symptoms, then infectious screening, malignancies screening, autoimmune screening, toxic or metabolic screening as well as paraneoplastic antibody panels should be considered.